Now we're going to talk about the benefits and some of the liabilities of NGOs working in the health sector, particularly in the low-income countries. There are very clear benefits, and I think the benefits have been one of the reasons why NGOs have grown so much over the past several decades. One is that NGOs have a tremendous amount of flexibility. They can move from place to place relatively quickly. They can do programs that aren't necessarily the old programs. Ministries of health or governments typically tend to be fairly reluctant to start new things because once they start them, there's usually a sense of entitlement that these programs should continue, so that the NGOs do have this ability to kind of move here and there, try out new things, and that's a tremendous benefit. And as you can see from the second bullet, testing new methods, catalyzing innovations is something that NGOs typically do much better than, say, the public sector. They oftentimes can bring experience in other settings, particularly these NGOs that have working in 120 countries, or maybe just 10 countries, but they're doing HIV work and they can learn from other countries. I've seen this in our own organization where we only work in 3 countries, but the lessons from one country to the other can be extremely beneficial. You can access international technical expertise either within your NGO or outside of your NGO, usually with much more facility than, say, a government can do. You have access to funds that are not directly available to governments, particularly, as I've mentioned before, that donor support, particularly bilateral donor support, is preferentially given to NGOs rather than governments for concerns about government corruption or concerns about government bureaucracy or the slowness that either money flow or programmatic initiation can start. NGOs can be more accountable to populations ignored by governments. Now, remember that NGOs typically are less accountable to governments than to their donors, but that sometimes has advantages when you have populations that governments either ignore purposely or ignore because they don't have the resources to be able to address that. So, for instance, there are populations in Myanmar, Rohingya populations, which have been served primarily by NGOs. Groups of people who are either minorities or who are considered to be a problem in many countries. Sex workers, for instance, have been better served by NGOs oftentimes than by governments. Important things that NGOs have catalyzed include working with refugees. Oftentimes this exceeds the capacity of governments to deal with the influx of refugees, particularly now where the numbers of refugees is so enormous. With disaster assistance, along the same lines, you have these big insults that occur either natural disasters or from wars or from political and or economic disasters, and NGOs can come in on a rapid scale or a rapid timeline in a very large scale and address some of these problems. They don't always do it well. As we've known, the situation in Haiti was totally chaotic with enormous numbers of NGOs coming in, very little coordination, lots of unnecessary overlap, and lots of wasted money. So, yes, they can do things governments can't do, but sometimes they don't necessarily do it in the right ways. They often have community-based work, and as I've said before, they can do things that governments don't necessarily do as well. The idea of developing community-based institutions or community-based interventions that can be community-based, NGOs oftentimes do this better than governments do. Or, for instance, in community-based follow-up of either tuberculosis or AIDS care or malaria treatment, etc., oftentimes NGOs have a better ability to move through the community than do government bureaucracies. NGOs have done tremendous work in advocacy. I think this is one of the major achievements of NGOs over the past couple of decades, particularly advocacy regarding the quality of health services or access to health services, around addressing social determinants of health, whether it's water, sanitation, education, etc., or dealing with inequities in healthcare, and in particular the issues around HIV. But if it had been just the responsibility of governments, I don't think we would have reached the levels that we're reaching today regarding retroviral treatment or AIDS treatment in the lowest income countries. It was the efforts on the part of Doctors Without Borders, Partners in Health, Columbia University, the Elizabeth Glaser Pediatric AIDS Foundation, or EGPAF, and our own HAI, that made a huge difference in pushing governments to initiate large-scale AIDS treatment programs, and by actually going out and doing some of these programs either with governments or on their own, to show that it actually could be done. And this had a huge impact on the governments, both thinking about the possibilities of doing AIDS treatment, realizing that it was possible, and by showing the public that it was possible to put pressure on governments to provide AIDS treatment. Okay, so those are some real positive things about NGOs. There are a lot of risks as well, or liabilities in NGO work. One is that NGOs typically have programming around vertical activities or disease-specific activities that's driven by donors. I've treated this as an advantage to NGOs because they can actually focus on these vertical programs, but oftentimes these vertical programs can be a liability because it pushes funding and activities of a Ministry of Health that has a responsibility to do everything into some of these very specific disease categories. So if you look at the PEPFAR initiative, this is a vertical program. $15 billion, 15 countries over 5 years. There were 4 major recipients for this, for what's called HAART, or highly active antiretroviral therapy, that a number of NGOs were involved in doing, each one of which got budgets of $100 to $350 million per year. Enormous budgets with enormous activities, had a huge impact. However, during this initiative, they followed PEPFAR's lead in terms of creating requirements and or preferences. For instance, originally the NGOs and PEPFAR required governments and the NGOs themselves to buy branded antiretroviral drugs, which meant that countries were paying $600 per person per year versus the $140 per person per year, which were the prices of a generic drug that could be produced, say, in India. The donors wanted a rapid increase in the number of people on treatment, and therefore these NGOs started creating their parallel services, doing their own care, rather than trying to use the public health network to make things work. And oftentimes NGOs would create what are called centers of excellence. The idea being that with an NGO, you can put lots of resources into 1 or 2 sites to provide the highest level of care, which is all well and good, but what are the implications for those health facilities that are not part of the centers of excellence? You have these oceans of mediocrity in these islands of excellence. And the problem is oftentimes the focus and the resources go to these few sites, and therefore the majority of the population that has access to these many sites that aren't, quote, excellent sites do actually worse than they might have otherwise done. In terms of AIDS treatment, most African countries received Global Fund resources for treatment, and the PEPFAR resources from the United States usually went through NGOs. So you had this mix where governments oftentimes actually had the drugs, and the NGOs were the ones that were working and distributing these drugs. Oftentimes, because these NGOs were already getting large amounts of money for these programs, most countries didn't want just one NGO to get them, so these 4 NGOs, and it's kind of expanded to probably major NGOs that are the major ones that provide HIV care, they divide up countries. So in the country of Mozambique, they divided up in Mozambique to, say, 5 or 6 regions, each one of which an NGO would provide, a big NGO would provide enormous budgets to their own staff to support the Ministry of Health to provide AIDS care. Same thing occurred in Uganda, where they divided up into 4 regions, in Cote d'Ivoire into 5 regions, etc. You would create separate drug procurement, medicines, systems of care that oftentimes didn't align to what was going on in the Ministries of Health, so that it didn't necessarily strengthen the Ministries of Health's capacity. And in many places, Ministries of Health lost control. The centers of excellence, the justification was to speed up access to ARV treatment or antiretroviral treatment, and to provide quality of care using the experiences of the NGOs, particularly their staff with high-quality logistic drug procurement. But usually they created parallel systems, that is, systems that couldn't necessarily be replicated, or at least paying people and having staff that might even be Ministry of Health staff, but at levels that were very hard to replicate. NGOs oftentimes created innovative approaches to HIV care, but they were often inconsistent with national norms. The idea was to work closely with and to strengthen the public sector, but oftentimes they would contribute to workforce and management brain drain, as we'll talk about in a second. So the second piece of the NGO risk are waste, because of the expensiveness of the way that these programs work, and phantom aid. Phantom aid means that the money flow from the donors typically goes to non-governmental organizations which have costs that typically never leave the home country of the NGOs. And that phantom aid that countries receive about 20 to 40% of the total value of this aid, providing very small amounts to ministries of health and oftentimes smaller amounts to direct service delivery. And this is obviously a major problem. With respect to phantom aid, the world's richest nations greatly exaggerate their aid to poor countries. With the United States, which is the worst offender with respect to phantom aid, some 2/3 of the money donated by the world's wealthiest countries is actually in this phantom aid idea that's not genuinely available for poverty reduction in developing or poor countries. This includes aid that is among all G7, which are the seven biggest countries in the world, that typically is not targeted for poverty reduction, that's oftentimes double counted as debt relief and aid, overpriced and ineffective, technical assistance estimated at $13 billion or almost $14 billion. It's tied to goods and services from the donor community country, which is the tied aid idea. It's poorly coordinated with the high transaction costs of these NGOs working in poor countries, which is estimated by itself at around $9 billion. It's fairly unpredictable because these NGOs move from place to place, or the funding from NGOs changes from place to place, and the funding to these governments is unpredictable. So it's oftentimes too unpredictable to be useful to the recipient government, and a lack of data actually prevents an estimate of the degree to which this is predictable. The money spent on immigration-related costs in the donor country, particularly for brain drain, is about $1.5 billion. And then there are all these enormous administrative costs to keep both the NGOs running as well as the administrative costs of the government. So it's pretty expensive stuff. So the third NGO risk is the issue of internal brain drain and the effect on the human resources of the country. So if you look at the brain drain, the salaries of the median Ministry of Health and NGO salaries in 2007, this is a study we did in 2007, were that the doctors that were expat doctors were at that time earning about $6,000 per month. It's now around $12,000 to $13,000 per month. A national doctor paid by an NGO might earn $3,000 a month, and this hasn't changed very much, even though the expat numbers have changed a fair amount. And a doctor working for the Ministry of Health might be getting $500 a month. For nurses, that distribution is even more skewed, and for administrators, it's even more skewed. So you have a situation where a driver for an NGO national driver will oftentimes earn substantially more than a highly trained nurse working for the Ministry of Health, and almost as much as a doctor working for a Ministry of Health. So it's kind of a crazy situation. And so what you have these people in the Ministries of Health who end up leaving the Ministry of Health for the NGOs or for some local in-country organizations because they earn so much, or they'll go to the donors. And this is what we call white follows green. That is, people in lab coats end up following the money. If you look at the neocolonization by the donors in 2002, which shows the fact that donors just had a lot of money and that their budgets actually exceeded the Ministry of Health's budgets for those periods of time. Well, that transferred in the mid-2000s to a neocolonization by the NGOs in Mozambique and other countries where each NGO, including our own NGO, Health Alliance International, would have budgets that exceeded by a substantial amount the budgets of the Ministry of Health, who in fact had staffs of 10 to 100 times that of the NGOs. Then there are the turf wars, is that NGOs compete because they're competing for money and they're competing for ideas. So many NGOs will come up to either having a particular program that they don't want another NGO to be able to implement, particularly if they have overlapping geographic areas, or they'll fight for abilities to work in a geographical area because the results of those fights, the winners of those fights, will actually be rewarded by enormous amounts of money. So NGOs typically work in low-income countries with this conceptual framework, which I would call would be a rhetoric of cooperation and collaboration. So they might have meetings, but they compete fiercely with one another to be able to get the donor money. They don't share budgets. They oftentimes don't share their plans because by sharing this, they can actually make themselves more liable to lose money. Another common problem with NGO-driven economies is they divert funds from the public sector services. Oftentimes you'll have beautiful new buildings that are funded by NGOs where the NGO staff might be working in, say, the part of a hospital that's been rehabilitated where the other part of the hospital is falling apart. And this is typical. You see this very frequently. You get pet projects of questionable value. I don't know how many solar cooking stoves I've seen over the past 20, 30 years that are the newest thing that will change development. And they come every 1 or 2 years. Different organizations have different ones. I mentioned the issues of wells, of different kinds of wells, different approaches to dealing with HIV care or malaria care. And all of this has fairly substantial implications on populations who get confused or ministries of health that get confused. Oftentimes they don't check with ministries of health or with the government about what the government is doing, and therefore it tends to be somewhat overlapping and redundant. And then there's this issue of inequality that's created by donors and NGOs. That the expat staff that are from the United States, Europe, or other countries around the world have salaries that are so much higher that they tend to become a visible local elite. They support luxury industries with luxury cars, hotels, etc. They live in gated communities. The nationals working for the NGOs and the donors become relative elites. The large budgets of the NGOs, which can buy all sorts of things, and their large salaries push up prices for the poor. And there tends to be growing resentment on the part of workers with their lower salaries who work for the NGOs. They have lower salaries but higher responsibilities, and they tend to be somewhat resentful of these high-paid international experts or local experts with the same training that they have that come in to help with salaries that are 5 to 20 times higher than theirs. Here are some images of inequality. On the left side, you see the kind of donor world. This is a hotel where the donors spend time in Mozambique. It's quite a nice place. I try to have lunch there occasionally myself, but it is highly inequitable. You have white Toyota Land Cruisers everywhere. This is actually an older one. And the expats spend their time on the beach, even though they're sacrificing to work in this global health field. What the nationals see are on the weekends or sometimes the weekdays where these folks are actually living a life of luxury. And at the same time, these are the conditions that people are living in, whether they're the general population or the nurses who work in the health facilities, side by side with the people who are the expat helpers. You get the next level of liability is the idea of parallel and fragmented systems. We've known this for years. Gilson did a study in Tanzania in the early 90s that where the perceived quality of services with NGOs was greater, even if the quality of services was in fact the same. That there are inherent structural inefficiencies of the NGOs. Oftentimes there's little outreach, increased cold chain failures, and less preventive services by health workers because they don't have the network that's been established by ministries of health over years, so that an NGO might have a couple of clinics and the Ministry of Health might have hundreds, if not thousands, of clinics in given areas. They often employ inadequately trained staff. It's hard for some of the NGOs to train staff, so they'll get people who they can get. So they're working side by side as these supporting people working within the ministries with their lower salaries who may know quite a bit more than they know. They've increased the quality, mostly related to the increased resources that they bring in. Now, one of the schematics that I find useful is to think about how NGOs typically provide services and support, especially when they don't have the capacity to provide services in the broadest way that ministries of health are forced to do with their network of services. So, for instance, in the country of Mozambique, you have maybe 1,500 to 2,000 health posts. The NGOs and the donors might support anywhere between 50 and 100 health posts. In a given province, an NGO might support 3 or 4 health posts, and the province might have 200 to 300 health posts. And so what typically happens, and let's look at, say, antiretroviral care or AIDS care, that when you do AIDS care, a primary healthcare system for antiretroviral treatment would be to start curative care at a central site where you have the most resources, where you might have the laboratory facilities, you might have drugs in the pharmacy, you might have monitoring and evaluation. So you'd start at a provincial level. So that would be the first place to work. And then you can gradually improve your care by expanding to districts, with providing, again, the drugs, the laboratory, the monitoring system, the capacity to do this. And then You might not do all the districts at once. You might just do, say, the 3 out of the 4 districts that have the most capacity. And then you would expand after that to some health facilities and maybe the 4th district, according to what the capacity has achieved during that period of time of supporting these facilities. And then ultimately you will get to all the health facilities as each one of these districts improves their capacity to manage and support these health posts that are providing the care. So that's the way that typically a Ministry of Health might work. NGOs, on the other hand, typically will have a limited group of health facilities that they'll work in because they don't have the capacity to work everywhere. And they also want to make sure that they provide a measurable and visible impact. So typically what they'll do, NGO 1 might support, for instance, one district health center, one health post, and maybe another health post that doesn't even have a district health center supporting it. So here you have this odd situation where you might not even have the kind of support that you need. You might not have the support at the province to the district level, and therefore you would get a parallel structure that's supporting the district level that might be in conflict with or might be aligned with the provincial support. NGO 2 might come in and support, and they might provide support to the provincial level, but on a different level or a different sort of focus than the first NGO will provide, and then they might provide at a district level here. So you have a much less organized support system, which is much less easy to expand in the same way that, say, the Ministry of Health would expand. But this is typically how NGOs work. So one of the things that I found interesting is that we looked at what happens to the expansion of new patients on antiretroviral care, of HIV care, in sites that are typically NGO sites versus government sites. And what we saw, and this was a fairly rapid picture that we saw, the numbers of people who were initiated on HAART or on antiretroviral care, what you saw was that the NGOs typically had a faster uptick, at least some of the NGOs, one didn't, but one NGO had a very fast uptick. But then after a while, they kind of leveled off because they only had a certain number of health facilities where they worked. Whereas the government tends to have a slower uptick because it takes them a while to develop the systems to work. And then once they get those systems going at a provincial level and at a district level, then they start increasing rapidly so that by the time, say, a year or 2 pass, the Ministry of Health numbers of facilities are far greater than you have with the NGOs that might be providing here in these examples 1 or 2 of NGO centers of excellence, but they really don't reach the populations or the numbers that the ministry might reach. This is an example of HAI, which is an NGO that works with the government, and how our working with government health facilities expanded rapidly. So that in 2005, we started an expansion with just a couple of the major facilities. We tried not to go into these peripheral facilities. And within a couple of years, we were able to expand from these few facilities, 7 facilities providing HIV care with, say, 2,000 eligible people or 2,500 eligible people on antiretroviral care, to 53 facilities by 2007. That was in 2 years. And by 4 years, 87 facilities getting 45,000 people in treatment. So you can see that with this network, you can provide much better care, but you've got to provide that support. So finally, what do the NGOs typically leave behind when their projects end? And this is one of the biggest concerns that I have with NGOs, because they will typically get 2 to 5 years of funding. Sometimes they'll get refunded for another 5 years, but they typically will leave. And what happens is that they leave a kind of a landscape that's littered with unemployed workers, with unemployed community health workers, with trained but not supported traditional birth attendants, with many people who had managed these NGOs who are now either working for other NGOs or may try to go back to the government, but usually get other kinds of jobs. And then they leave this hardware around, whether it's laboratory and hospital equipment that's no longer maintained, or water systems, or tractors and agricultural equipment, or vehicles that don't work. And literally you see the landscape littered with this stuff. Ministries of Health are slow, they're bureaucratic, they're dependent on a few people who travel all the time, and the health workers are frequently absent because oftentimes they're getting training and per diems that can supplement their very low salaries, and their workforce expansion is a principal bottleneck that's limited by ministries of finance. But have this broad healthcare network, they're oftentimes more capable of health services for the poor, They're oftentimes the best option for sustainable systems and rapid access, and that they're approaches to helping ministries of health actually do their work that can be a counter to the approaches that have been used by donors who fund NGOs to do the work.